this is very simple. Anybody wants to answer what is this?
This exaggerated triggering kind of, sir, some flexor tendon.
Dupuytren's contracture.
Yeah, this is Dupuytren's. It was simple. Don't expect too many funny things. Yeah, this is Dupuytren's contracture. So you will see a lot of patients who come to rheumatologists for this. Unfortunately, nothing much to offer, though sometimes tendon sheath injections can help, sometimes surgeries can help, but recurrences are quite common. You have to address any diabetes or alcoholism in the background if that is the case. So should we go to Dipti again? Dipti, have you joined?
Yes.
Yeah, so following two regarding thrombocytopenia and APLA, it is usually mild. It requires treatment with steroids. Mild to moderate thrombocytopenia abrogates the risk of thrombosis, and there is decreased bone marrow production of platelets in APLA syndrome. What do you think is true regarding thrombocytopenia? And only one option is correct.
First
this
one.
is all clinical stuff. Yeah. Which one?
First one. Option 1.
First one. Oh, excellent. So this is what I want to. So basically, when you have incorrect options, you learn more out of it in MCQs, and this is how I want it to be. That thrombocytopenia is usually mild in APLA syndrome. You may have platelet counts of 70,000-80,000, but usually above 40,000 is considered okay. It usually does not require treatment with any immunosuppression, and it does not abrogate the risk of thrombosis in APLA syndrome. Be very clear on that front. And it is more like an peripheral destruction of platelets, something like an ITP rather than a decreased bone marrow production. You may have an SLE or non, but when you're talking of APLA syndrome and thrombocytopenia, you're considering that we are not talking of patients with SLE with APLA syndrome, because they can clearly have thrombocytopenia. But pure APLA syndromes can have thrombocytopenia. So Dipti was Ajit, you want to answer this? What is the ANA pattern and significance here? I've given you 2 slides. If you remember the case discussion, everybody talked about looking at the cells with interface and metaphase. Even if you don't identify the pattern, it's fine. If you give me the description, that is good enough for me. Ajit, you are here? If Ajit is not here, somebody else wants to attempt this?
But I think he's here.
Ajit is here?
Aditi, you can answer. Deepti, you can answer otherwise.
Then find second, sir, because the metaphase plate is straight.
There is a lot of disturbance from somebody. Can you mute yourself?
Sandeep sir will have to mute, I think.
Yeah, dense fine speckled, excellent. That is excellent. You have, I think Sandeep is teaching your patterns well. I could see from that your past ANA slide also. Or maybe you are learning well on yourself actually.
No. Credits to
Sandeep. Yeah. So there are 2 things. The interface will see you a lot of core speckling, but there will be something which is fluorescent, something which is not fluorescent. The nucleoli are spared. You can see those hollow spaces. And the more important thing is this metaphase chromatin is very dense, and it is like really looking densely fluorescent. And this is what it is known as dense fine.
And Aditi, hello.
Yes, sir.
So what is DFS pattern associated with?
DFS is actually a non-pathological. They say it is non-pathological.
Excellent. So yeah, it is usually non-pathological, and yeah, you will see a lot of DFS patterns being reported, and generally it is a reassuring thing. Okay, most likely there is no underlying autoimmune disease, and there are now terminologies by ICAP like AC1, AC2, AC3 when you are reporting ANA patterns. I think it is AC27 is the last one, and I think DFS will be reported as AC2. So you should be aware, because now you'll see reports with this kind of reporting, especially from good
There
labs.
is still AC 29 also, no sir, because total
Yeah, I
29,
mean,
I think.
I last read of 27, but you never know. It may change tomorrow also.
Okay.
Yeah. Okay, so I think Aarti, which is not true for rheumatoid vasculitis, it is similar to PAN. Presence of leg ulcers require aggressive immunosuppression, especially isolated leg ulcers. It usually occurs in patients with long-standing seropositive nodular arthritis, and complement levels can be very low in rheumatoid vasculitis. What do you think is not true here?
So I'm not
Aarti?
sure, but I'm not sure. I'm not confident, but probably option A.
No. So rheumatoid vasculitis is very similar to, it's like medium to small vessel vasculitis, which is what PAN is. And it usually is obviously associated with long-standing seropositive nodular rheumatoid arthritis. You can have low complement. The only time when rheumatoid arthritis pure rheumatoid arthritis patients can have low complement is with very severe vasculitis. I want you to be concentrating on leg ulcers. You will see long-standing rheumatoid vasculitis with leg ulcers. And sometimes because of vasculitis, we tend to think that we should strongly immunosuppress them. Actually, it's not correct. In fact, many a times you have to withdraw steroids because that is leading to poor healing. And you should optimize your methotrexate and give them good dressings. And sometimes that alone is itself helpful to control the leg ulcers. In isolated leg ulcers, if you want to use a steroid sparing agent, yes, rituximab is a very good drug for rheumatoid vasculitis. But does rheumatoid vasculitis in the form of isolated leg ulcers warrant strong immunosuppression? Is controversial. At least I try to get away from steroids, because poor wound healing becomes a big problem in these patients, and steroids are very bad for wound healing. So do remember that not every vasculitic ulcer you see in rheumatoid patients needs aggressive immunosuppression, but you have to see the context. If there is a lot of mononeuritis multiplex, corneal melt or stuff like that, then you need to definitely aggressively immunosuppress. But again, try to spare steroids, because leg ulcers will be a big problem if you keep on using a lot of steroids in this patient. Who is this for? Aditi. So in Felty syndrome, a triad of granulocytopenia, splenomegaly, and arthritis, all of the following are correct except DR1 association, association with expansion of large granular lymphocytes. Again, occurs in long-standing severe seropositive disease, and joints may be cushioned. What is wrong among all this?
B, sir.
Oh, no, it's A. So it's usually HLA-DR4 association, and for some reason, I don't know how often do we see Felties as consultants, but it definitely appears to be more reported in Caucasians. It definitely is associated with an expansion of large granular lymphocyte. It may get converted to a large granular lymphocytic leukemia, which is rare. But expansion of LGL cells may be seen. And if it goes beyond a certain clonal percentage, then we call it a leukemia. But you can see by flow cytometer certain subset of large granular lymphocytes expanded in Felty syndrome in a huge, almost 40% of patients. So it's A which is incorrect. The rest three are important for you, even from a clinical point of view. I am not keeping any scores. I hope that does not matter at this point. So audience question. 46-year-old audience or some fellows can answer. 46-year-old, maybe from the other than the remaining 4 who are part of the quiz. 46-year-old man presented with 2-week history of a worsening ulcerative rash over the lower limbs, right knee and wrist synovitis. He also has ulcerative colitis during the previous 5 years and was taking prednisolone 5 mg daily. What is the most likely diagnosis?
Pyoderma.
Yeah, this is straightforward. Yeah, pyoderma gangrenosum. You can see very bad pyodermas in these kind of patients, and I think that was quite straightforward. I don't know who answered that. Well done. So Deepti, you again.
Yes.
Now I'm going to more of complicated clinical scenarios. I should finish in next 10 minutes if somebody needs you to leave the session. But do note that there are some interesting questions out there which can really rack your brain. So stay with us for 4 minutes. So a 23-year-old unmarried female of SLE presenting with class 4 nephritis with adverse histological features, treated with Lupus protocol of 3 gram cyclophosphamide fortnightly, followed by maintenance with azathioprine along with steroids, has achieved only a partial response in 6 months. What will be the best course of treatment for her and why is the question. This is a scenario you will face in your real life, and tell me, what do you think here? There is no 100% answer, but I'm just trying to see what you think of this. So Deepti?
That I would probably switch to mycophenolate mofetil 3 grams per day, because she's 23 years and unmarried. So giving another course of a high dose cyclophosphamide in such scenario can predispose her to infertility. Then next reason would be she doesn't have any adverse histological features as you have mentioned. So MMF is still a good enough option in such a case, and try to see the response. And since she has not had any, only a partial response at 6 months, I would not continue the same line of management. So
when do you think you should change? What is the guideline kind of?
If I'm not mistaken, at 3 months at least we should see this partial response, and at 6 months it should almost be a 70 to 80% response, and just a 50% would still not be satisfactory.
Yeah. So most lupologists will say at 3 to 6 months partial response is decent enough. At 6 to 12 months is a complete response. So maybe not changing is not a bad option at this moment. She may achieve. And suppose if you are predominantly having a proteinuria with a quiescent urinary sediment, I will probably escalate the ACE inhibitors at this point. Because changing is very easy, but you do understand that it will take time if the histology was adverse. The other concept here is some may say that we should go for rituximab because it may give a long lasting remission, but we have already committed to something, so let's give it time is what we are. But I said there is no right or wrong option, but don't be in a hurry. If your urinary sediments have settled, the proteinuria usually settles. And if suppose your proteinuria was, let's say, 4 gram, and it has come to let's say 1.5 or even 1 gram, you don't want to achieve that 500 milligram very suddenly. Also, that's no need to change the therapy. So do understand that context here is important. And generally, if your patient is improving, the urinary sediments have gone silent, the proteinuria has decreased by at least 50%, and especially if the UPCR has gone down below 1, not below 0.5, there is no imminent need to change the therapy, basically. So that is what I wanted to highlight here. But don't be in a hurry to switch therapies, because you will find that sometimes even that becomes difficult at times. So, and the reason why we say so, because even if you change to mycophenolate, the ultimate long-term outcome by evidence does not change that much if she has achieved a partial response, especially with low proteinuria. So next, Ajit, you are here. There is still a lot of disturbances from some phone. I don't know who is not muted. Ajit, you are here.
Yeah, sir, I'm here.
So, Abhishek, is your phone unmuted? I don't know. So, 20-year-old main complaint, Ajit, for you, 20-year-old main complaints of arthritis and redness and irritation of eyes. He has a history of burning micturition. On examination, there is a joint effusion of the right knee and a rash of the glans penis. Which of the following is correct? AN is likely to be positive. The etiological agent is likely to be Neisseria. The patient is likely to be rheumatoid factor positive, and GI tract infection may have precipitated this disease.
Fourth one.
Which one?
Fourth one.
You have to tell me the description of the option. I can't hear you. First, second, fourth. You mean, yeah. Yeah, why not Neisseria gonorrhea? Can't hear you, Ajit. Okay, so I'll take it from here. Yes, I agree. The GI tract infection can be the precipitation here. The burning nephruration which is seen in reactive arthritis patient is usually reactive arthritis, and it may lead to sterile pyuria. It does not, and usually the infection precedes the reactive arthritis presentation. So the GI infection may have precipitated a reactive arthritis like presentation. I think somebody should call Abhishek. I think he's having his phone on. I think so. So gonorrhea infection usually will lead to fever and acute prostration, unlike this typical presentation of reactive arthritis. Everybody agrees on this, or is there some difference of opinion here?
Yes, sir. I'm agree.
Yeah. So next question to Aarti. Which of the following is true regarding HLA-B27? The frequency of HLA-B27 is inversely related to frequency of spondyloarthritis in Northern Scandinavia. It has 5 subtypes. Subtypes not associated with spondyloarthritis are 109 and 106. And chances of developing AS are increased by 5% in HLA-B27, or risk, or not chances, the risk of AS is 5% in HLA-B27 first degree relatives of patients with angstpon.
Yeah, just
Aarti, you are
unmute
here?
yourself to answer, then again mute
Yes.
yourself.
Yes, sir. I had logged out. Sorry. I'm there.
Aarti, you can see the question?
Yes, sir. Yes. Once.
Yeah. The thing is that just look at what do you think is not. Sometimes in MCQ you have to look at what cannot be incorrect, and that will be indirectly true. You may not know all the options correctly, but you know at least what is true or what is false.
So option D, the chances of developing AS are increased by 5% in HLA-B27 positive first degree relatives of patients with angstpon.
Yeah, so they say it is 5 to 10%, and if you have symptoms, it is usually up to 20% also. So in this was a bit of confusing thing, and there is a bit of controversy here, but I let it be. Ideally, it should be 10% here, but yes, I think the other 3 are incorrect. HLA-B27 has 27 subtypes, and it's directly proportional to frequency of spondyloarthritis in Scandinavia. And I think 109 and 106 are associated with AS subtypes. So I think Aditi, regarding autoantibodies in lupus, incorrect statement is anti-SM and anti-RNP are directed against small nuclear ribonucleoproteins. Anti-RNP antibodies can be found in 20 to 30% of lupus patients. Anti-SM are virtually always associated with anti-RNP, and anti-Rho and anti-Rho 60 and 52 are directed against different molecular weight proteins of same cytoplasmic RNA complexes. I've given you a picture of U1 RNP also, just to make it a bit interesting. You're here, Aditi?
Yes, sir.
There are 2 contradictory statements here, so there should be one of them should be incorrect.
B, I guess.
Yeah, B. So usually SLE has diffuse epitope antibody formation. So generally, if you have at this SM portion, this core protein you can see here, this B, B dash, D, E, F, G is the SM portion, and then it gets attached to RNA complex, and this gets attached to this U1 protein complex, which makes it a ribonucleoprotein. For some reason, as antibody, if you see a lupus patient's profile, the blot will always be written as anti-SM positive and anti-SM RNP, both will be positive. Vis-a-vis the MCDD profile patient where only SM RNP positivity will be there. Because when you put an antigen on the blot, they can either put a whole SM RNP antigen or an isolated SM complex. They for some reason can't put a RNP complex isolated on a blot. Unlike in ELISA, in ELISA you can get an isolated U1 RNP antibody, but not in a blot. So in most lupus patients, you will have both SM and SM RNP being positive. And SM is positive, usually SMRN will be positive. Isolated U1 RNP is seen in MCDD patients. So in MCDD patients on a blot, you will see SM/RNP positivity. And this also tells you why SM and RNP are talked about in the same breath in many antibody panels. So if you have a blot with only SM RNP positivity, that is more likely to be MCDD. But if you have a blot with multiple antibodies positive, including SM isolated and SM RNP both positivity, which is usually the case, which is the statement 3 in this case, then it is usually seen in patients with SLE. So this is again a real life scenario. Audience questions: Bywater's lesions are described in. What are Bywater's lesions is what I want to know. What are they?
Periungual reddish.
Yeah,
lesions.
excellent. So something like a nail bed infarct or something like that. Excellent. So that's good. But yeah, it can be seen in many other lesions. It was described in RA, but not necessarily specific. Again, audience questions: earlier erosions of plain radiograph of feet in patients with rheumatoid arthritis occurs at which area? This has a clinical relevance. This is the most common site of pain in many early RA patients. If you can't find pain anywhere,
Fifth metatarsal.
Fifth metatarsal.
yes, fifth metatarsal. I think it's base, not head. I think not head. I think it's the base which is the most common involvement. Fifth metatarsal base, or you call it, I think it's called base. Yeah, it's the base which is the most common involvement. So, Deepti, question for you.
Yes, sir.
So 45-year-old female with 10-year history of inadequately treated rheumatoid arthritis with RF anti-CCV positive, presenting with high-grade fever, myalgias, possible mild vessel weakness and weight loss. Blood workups reveals high SR, high CRP, leukocytosis, low C3, high C4, positive ANA, positive Rho antibodies, high ferritin, normal CPK and liver enzyme levels. Creatinine is deranged. There is hypoalbuminemia and hypergammaglobulinemia also. There is slight elevation of UPCR with some pus cells, occasional scars. You can see almost something like a bywater lesion. Patient is looking not so well. So what do you think is the diagnosis we are pointing at here?
Infective endocarditis.
Excellent. So not everything in rheumatology is rheumatological. You will always have patients who present with different pictures. There are many clues here.
Yes.
First, the nail bed
Only
infarct.
low C3 only,
Yeah.
other C4 weak.
Yeah, and low C3, high grade fever. Even if it was low C3 and C4, I would have still thought of infective endocarditis as a first feature, though low C4 becomes a very unusual phenomena in this. But you never know what. But at least you will do a screening echo and send blood cultures. And rheumatoid vasculitis, though, can present with unexplained fever. This kind of high grade fever, short duration, with so many other features, makes RA vasculitis less likely. You may have a coexistence of a low-grade RA vasculitis, but at this point, this picture appears to be suggesting infective endocarditis. So kudos to you, Dipti, for identifying this. That's why I wanted to highlight that in real life, you'll come with presentations like this, which are very complex and difficult to make sense. So don't forget your medicine. Always try to be a good medicine person first, rather than being a brilliant rheumatologist. That comes naturally if you're a good at medicine. So Ajit, you are here?
I'm here, sir.
Yeah. So a previously well patient presents with 1 week history of fever, altered sensorium, peripheral gangrene, and focal deficit. So his investigations reveal low hemoglobin, slightly leukocytosis, platelet is 84,000. SGOT PT are raised, bilirubin is 3, indirect is more, creatinine is deranged, LDH is raised, PT is normal, APTT is prolonged. What do you think is happening here, and what is the likely diagnosis? HUS or DIC or TTP or CAPS? and why? I need some reasoning.
That
There are many clues out here.
within a period of 1 week, there is dysfunction of 3 organs, that is spleen. One is neurological involvement, second is cerebrovascular involvement, and third is quality.
Yeah. So no, but that can happen in TTP also, DIC also, HUS also, 1 week history, and CAPS also. So what is your answer here?
So my answer is CAPS.
I need more better reasoning. Somebody else can give me.
So APTT is deranged, PT is normal.
What
So
will be seen in
ideally
DIC?
Yes, sir.
Yes, thank you. Yeah.
Yeah, ideally in
Absolutely
DIC,
correct.
the INR, like APTT or everything should have been deranged.
Excellent.
TTP
Excellent.
HUS derangement is unlikely. Like INR is generally
Yes.
not deranged in those cases. So
Yes,
CAPS.
and TTP HUS, you won't see the derangement. TTP HUS, sometimes the platelet is much lower than what we are seeing here. And there is definitely microvascular hemolysis, which can be seen in all of them. So because there is high LGBT, low hemoglobin, and indirect hyperbilirubinemia. So this is very confusing at times, because and peripheral gangrene is not very common in TTP HUS. It can be seen in DIC, but DIC may PT should be prolonged. There cannot be a DIC without a PT prolongation ideally. So many clues here which are pointing towards CAPS. So altered sensorium, low platelet, and microvascular hemolysis can be seen in all of the four, but more common in CAPS and TTP. PT prolongation should be seen in DIC. Low platelet should be much lower in TTP, HUS kind of or DIC kind of picture. And APTT isolated prolong is very much pointing towards CAPS. Why so? Why APTT prolong?
Presence of lupus anticoagulant.
Yes, so presence of lupus anticoagulant, which causes in vitro APTT prolongation, but in vivo it causes thrombosis. So it is a confusing concept for many, but this is how it is, because when you are testing APTT, you are actually getting blood and doing it in a tube, which makes it different from when it is in the body. So antiphospholipid bodies in the body, they have a phospholipid surface and they cause coagulation. But when do it in vitro, they inhibit coagulation, and that's why the APTT is prolonged. So this is a concept which you should be aware of. I think this question is for Deepti again, or no?
So it's for me, Arthi.
Aarti, sorry. So 74-year-old lady presents with a history of gradual weakness in her legs to an extent she can no longer walk. She complains of back pain, numbness to both legs. There is no history of urinary or fecal incontinence. She has no past medical history except for previous carpal tunnel and cervical spondylosis. On examination, there is full power in upper limbs. The legs are weak with absent knee and ankle jerks. And there is loss of sensation to pinprick at both feet soles and back of legs. There is perianal numbness and reduced sphincter tone. So what is the next appropriate investigation here? A nerve conduction study, a bone scan, a MRI cervical spine, or a MRI lumbar spine, or a X-ray lumbar spine?
MRI lumbar spine.
Why?
So the patient has both sensory motor symptoms with absent reflexes. So more likely pointing towards radiculopathy.
Excellent. So we are probably looking at a cauda equina syndrome.
Yes.
Yeah. So this is a pure medicine question, just to make it interesting. Maybe a pure neurological medicine or something which you will see in practice when patients don't have rheumatological and something totally out of context. And you do get a lot of radiculopathy patients in your private practice. So be very sure of your neurology examination also while you are evaluating this kind of patients. And excellent. So MRI lumbosacral spine will be what I will order. And it will definitely relieve some reason for her cauda equina like symptoms. So this is to Aditi, I guess. 50-year-old woman presented with a 2-month history of severe pain in knee, calf, and foot. The pain has developed 1 week after a meniscectomy. Examination, she was tearful. Her right leg was swollen, dusky, cool, and tender. Light touch was extremely painful and refused to have her knee fully examined. CRP was less than 10. What is the most likely diagnosis here? This is easy. I think so. I think Aditi is the one who. Synovial leak. Oh, possible. I would still have asked the CRP to be higher. So I think that does confuse you, but we are pointing towards something else. Next second best guess.
Complex.
CRPS.
Yes.
Yeah, this is very classical presentation of CRP, extreme hyperalgesia, which may not be seen in synovial leak. This is very classical CRPS. You have an antecedent trauma following by a regional severe hyperalgesic limb with vasomotor changes, which fits all the criteria. You should be aware of the again somewhat classification criteria known as Budapest criteria of CRPS, where you need vasomotor changes with extreme hyperalgesia with an antecedent trauma history to make a diagnosis. And these are very difficult patients. They seem like inflammatory arthritis, but there is no inflammatory arthritis. And it's very, very difficult to treat them. What is the line of treatment you will follow in such patients? Any comments?
Famindronate can be tried.
Yes. What is the first and most important thing? What is the most common cause of CRPS, which is actually done by doctors? What is the most common cause of CRPS you see in real life? And what do you do for it? Any example? Anybody aware of it?
No, sir.
So when you plaster a hand or plaster a limb after fracture, you are actually immobilizing a limb post fracture, and that introduces some kind of sympathetic dystrophy in that hand. And whenever you remove the plaster of that hand after 4 to 6 weeks, you will see a lot of vasomotor phenomenon in that hand, a lot of shiny skin. They may have lost hair on that skin. That is like an induced RSD. And what do you do after that? Aggressive physiotherapy. This is what you should offer to most patients. In the initial wet phase, there is controversy whether you should use steroids or not, but definitely it helps to tone down the inflammation. Pamidronate is an option, but it does work well in certain set of patients. But the way it has been reported on internet, it is controversial because there are no randomized trials. I usually make it a point to make it very aggressive physio. And the physio is very, very difficult because it is very, very painful for patients to do physio. And that is the biggest roadblock to getting these patients well. We don't know how physio works, but aggressive physiotherapy is something which works very well. May or may not use steroids and bisphosphonates, depending on the phases. Usually, if it's phase 2 or phase 3 where atrophy sets in, usually nothing works. So you should identify this syndrome very well, because once you have dystrophy, stage 3, which usually takes 3 to 6 months, it's very, very painful, and they remain painful for life. And they may have secondary destruction of joints, something like a Charcot's joint, without actually having diabetes. So it's very important to diagnose CRPS. Is there any test which can help you to diagnose, though that test is not specific?
Triple phase technetium bone scan.
What does it do? Why do you need a triple phase? And why not a single phase?
I don't remember exactly, but in second phase there is a retention.
Okay, so inflammatory arthritis always will show uptake in the initial phase, and this is an inflamed limb, so it will show initial uptake. But what happens, there is a delayed tracer release. The tracer does not get washed out. So there is a delayed images also show a good amount of tracer. So you need a third phase to document that the tracer has still remained in that particular limb. So the clearance is not good. It's not a very good test if you use it in real life. In real life, always use your brain. And if you see a CRPS of 3 to 6 month duration, if you see the X-ray of both limbs together, you will always see one limb more osteopenic, and that is usually a very classical sign, but it does not occur in the early phase. So I have used triple phase scans a lot, and the response has been touch and go. It is sometimes helpful, sometimes not helpful. But if you have a patient who has a diffusely painful limb, which is not explained by anything else, without even a clear history of antecedent trauma, always think of CRPS in that setting, especially because they can have erosions also and bone edema also and MRI. So you may confuse it with arthritis. But if the inflammatory markers are absolutely normal throughout the course, then don't think of inflammatory arthritis easily. So these were my 16 questions. 2 or 3 more questions if somebody wants to answer. Regarding IBD associated arthritis, which is the true, peripheral arthritis affects around 10 to 20% of people. Flares of arthritis occur together. Spinal involvement is related to large bowel activity, and methotrexate is first line treatment for arthritis. Anybody wants to give it a go, audience?
Flare of arthritis and colitis occur together or are together?
Oh, sorry, these are together. Occur together, basically. I meant to say occur together. Yeah. So I want
rarely occur together, I think.
Yeah. Yeah. So I think, yeah, sorry, I made a mistake here. So usually it is seen in 10 to 20%. So maybe first option. And if it was rarely occur together, even that is correct. Spinal involvement is not, but the second and third statement are kind of contradictory. But spinal involvement, the arthritis does not go hand in hand with IBD activity. We did see one case where we had given an example of pyoderma gangrenosum, where the pyoderma and arthritis occurred much later after the IBD was settled. And usually sulfasalazine is the first line because of its gut activity, and it is cheaper than 5-ASA also. So it is helpful that way, but even methotrexate can be the first line if the arthritis is severe. But I just wanted to highlight some facts rather than be very specific of the MCQ here. Again, an easy one, Caspar classification of psoriatic arthritis does not include
Erosions.
Why?
Psoriatic arthritis usually have new bone formation, so it includes new bone formation.
Excellent. So yeah, so this was a relatively easy one. So 24-year-old woman presented with acute pain and swelling of her right knee. She also had lower abdominal pain. On examination, her temperature was 38 degrees. Right knee was warm and tender with a tense effusion. There were pustules on the right knee. What I'm suggesting at? There was a clue in the earlier MCQ at some point. So gram stain is negative. Yeah, it's possibly gonorrheal infection. As I said in the earlier reactive arthritis presentation, there was no acute fever, so probably it was precipitated by a GI tract leading to sterile urethritis and causing the classical triad. Here we probably have a sexually active woman who has got a gonorrhea infection, got pustules. Usually this patient's synovial fluid does not stain for gram staining, and the blood cultures are positive. So this patient needs antibiotics, and the CRPs are also very high here. So we are definitely indicating towards infection, and more so Neisseria, which is classical presentation of gonococcal arthritis. I think this is the last one. Raw antibody asymptomatic mother with a history of delivering a previous child with CHB has conceived again. Should mother be given prophylactic steroids to prevent heart block? And what is the best option here? No, she should not be given because steroids are metabolized by placenta and hence will be of no use. No, she should not be given because there's 80% chance that this fetal will not have a heart block. Yes, she should be given because fluorinated steroids have been shown to prevent heart block when started at 16 weeks. And no, the risk of prophylactic fluorinated steroids is much higher to fetus as compared to advantage in current situation. So what will you do? Anybody?
C.
Option C.
We will give.
Will give in all patients?
No, if the patient
With previous history.
Yes. So here the option D appears to be most appropriate. We will not give her now. We will give her if there is some problem and there is a PR, at least grade 1 block, type 1 block happening, like prolongation of PR interval, and we are monitoring the fetus right from 12 week onwards, 8 to 12 week onwards, where we continue to prolong the PR interval. And if you see any evidence of early heart block, you will use fluorinated. You will not use it prophylactically. That was the question here. You will not give fluorinated steroids to everyone. because you're talking of almost 4 to 8 mg dexa daily, which is got a lot of toxicity. And even that is not known to be conclusively inhibit, but you are giving your best fighting chance. So what is the chances of having CHB again in this child when the mother has already had one CHB? What is the chances if you are Rho positive and having a congenital heart block? How much percent?
2%.
If it is first time, it is 2%. If
2%.
Yeah,
mother
1
has
to
had history,
2%.
it is
And
17%.
18 to
exactly. So it is close to 20%. So the second option is also correct, but prophylactic steroids, no. But we will be in a close lookout and we'll use fluorinated steroids in 4 to 8 milligram or maybe even 10 milligram doses if we are seeing any kind of PR prolongation. And even that is controversial, but we may give a fighting chance to the baby. So this was it. I hope you found it interesting and clinically relevant and not very theoretical. That's why I try to choose MCQs. Some I have really picked up from my real life scenarios and put it here. And I hope this was of use to you and you learned something out of it.
Yeah, it was excellent. I think, it was just too good. Just that we had little technical glitches today. So sorry about that. So thanks for staying there, Dr. Nilesh, because you had to
Thank you,
wait
ma'am.
also a little. Yeah, really happy to have you today. Students,
Thank
you
you,
want
ma'am.
to thank him?
Thank you.
Hello?
Thank you, sir.
Thank you, sir. Thank you.
Yeah.
Thank you, and sorry to bore you guys on a Sunday, but
No,
I hope at least it was some interest.
no, the questions were fantastic as usual. So Dr. Nilesh is a real excellent quiz master, So we'll see more of you very soon. Thank you so
Thank you,
much,
ma'am.
everyone. Thank you, Nilesh. Thanks a
Thank
lot.
you. Thank you. Have a nice Sunday, everyone.
Yeah, you too. Happy weekend to all of you. Yeah. Bye-bye. Good day.
Bye.
to you.
Bye. Bye.
Thank
Bye.
you, ma'am. Bye.